Hello and welcome back to the How I Rehab podcast, brought to you by the SportsMap Network. I'm your host, Nick Kane. Today we're chatting with Luke Heath on the common deficits you'll find within an ACL rehabilitation, and Luke takes us through some really great detail on how we might address those deficits and get the optimal outcome for athletes from an ACL repair. Now, Luke Heath is a titled Australian Physiotherapy Association sports physiotherapist and holds a Masters in Sports Physio. Now, Luke has substantial experience working in sports. He has worked in professional sport for over 10 years. He was the head physio at the Sydney FC in the A-League in Australia, and prior to that was a senior physiotherapist and the rehab coordinator at the GWS Giants in the AFL, and then also had his hand in rugby prior to that with the Manly Sea Eagles. Luke is now one of the senior physiotherapists at Aspetar, working in around the knee space, and seeing all manner of athletes from across the world come over and utilise his expertise as well as the teams there in getting insights into ACL rehabilitation. So Luke recently talked at the Aspetar conference and also the IOC conference around some aspects within knee rehabilitation, and want to chat to him today around trying to break down, I guess, some of those common deficits that we as clinicians might find when working with an ACL athlete, and then how do we navigate through some of those pitfalls and try to come out the other side with the best rehabilitation possible. So we do that with Luke, and he gives great insight into a few different deficits and also further insights into how do we improve those and break that down from a rehab and exercise prescription setting. So really enjoy this podcast with Luke. Now, for those with a really keen interest in ACL, we have a tremendous amount of resources in that space in our SportsMap Masterclass. We had Lachlan Batty, who took us through some of the orthopaedic testing, early stage and decision-making around ACLs and other knee injuries. Furthermore, we have Edna King, who is the head of Aspetar, where Luke works, and he took us through addressing and exploring and assessing foot and ankle stiffness in an ACL rehabilitation. And then we have Matt Konopinski, ex-Liverpool head physio, who took us through more some end-stage aspects around trying to tease out deficits also within ACL rehabilitation using the ISET Kinetic and using some of his biomechanical analysis. So it really ties nicely into what Luke was talking around today. So I guess those three masterclass episodes there are probably the ones that I'd highlight. So again, a reminder, that is an annual subscription there, or monthly. You get 7 days free. It's around $25 a month, and you get full access to all the content, and you can use that in your own time. There's a new masterclass coming every single month, and they are 60 to 90 minutes, interactive and practical masterclass videos with the top clinicians that we have around the world delivering that content. So highly recommend you check that out. All right, and event-wise here at SportsMap, we have a lot coming in the next 12 months. So let me just fly through this quickly, and I encourage you just to head over to sportsmap.com.au and check out the full lineup of live events coming. July 10th, we have the Problematic Plantar Fascia, which is an online roundtable event. Limited places remain for that. Then we're in the US the end of August, running the How I Rehab Lower Limb with Brian Heiderscheit, Seth O'Neill, Susan Sigwid, and a couple of other all-time presenters, including Rich Willey. So looking forward to that. And then a brand new event announced, which is Solving Soft Tissue Injuries, which is going to be a conference-style event here in Melbourne, February 8th and 9th, 2025. So already a lineup being added there, so you can head over and have a look. And that includes the likes of Dave Opar, Seth O'Neill, Scotty Hulme, who we had on here in a podcast, Sam Peach, who's doing a PhD in quad injuries, and we're going to bring together some other tremendous presenters from both international and national in Australia. And so looking forward to that one. And keep your eyes out for a Brady Green calf course, which is a one-day workshop coming in September. So lots going on, plenty there for everyone, big focus on soft tissues. So really trying to get ahead of the game there and what we're doing, how we're managing those injuries, hearing from some of the experts from around the world. So looking forward to seeing you all at some live events, and obviously staying in touch with what's happening with our masterclass platform to make sure you're getting all your CPD needs across the year. Okay, let's get into the chat with Luke Heath on some common deficits in ACL rehabilitation. All right, well, welcome, Luke, to the How I Rehab podcast.
Yeah, thanks for having me, Nick. Appreciate you having me on, and mate, you're pumping out some really good content with some really good presenters, and I'm humbled that you've asked me on, mate. So thank you.
No, thanks, mate. Appreciate the pump up, and I'm looking forward to chatting with you a little bit around your background and where you worked, and now how you're working largely in the knee department at the Aspetar Hospital with some great physios there that you work with, and how you ended up working there. But also, then we're going to sort of break down, I guess, ACL rehabilitation. Rather than trying to go through the whole thing, we're going to probably try and tease out 3 key deficits that you and your team pick up in ACL, and then I guess out of those deficits, how do we address them? So that's hopefully our clinical rehab takeaways from today's podcast. But mate, for those that wouldn't have heard of you too much, fill us in a little bit about your background, and what you're doing now.
Yeah, so I started out in a clinic on Sydney's Northern Beaches at the Sydney Academy of Sport, and as a young physio, I got some good training and exposure here, which laid some solid foundations for me as a physio, which I'm very grateful for. So from there, I started to cut my teeth in pro sports, working at Australian Rugby Union with the Aussie Sevens, and I then moved on to working at GWS in the AFL for a stint where initially I was the rehab physio, and the role developed into a senior physiotherapy position. Whilst I was at GWS, I started up a clinic named High Performance Rehab and Sports Physio with Chris Bailey, who is the current head physio at Manly Rugby League, where I did some consulting, and I'm still a partner at this clinic currently. So from GWS, I then moved on to Sydney FC as the head of medical, and basically I had a 10-year stint in pro sport, which I really enjoyed. I enjoyed the intensity of the roles, and the problem solving and the roundtable discussions on how best to manage a case. And we're seeking to improve and do better for athletes, not only for their care, but to get a competitive advantage so the team can win. And this is the part I really enjoyed of working in professional sport. So, which brings me to the now. Currently, I'm working over in Qatar in the Middle East at Aspetar as the senior physio in the knee department. And here I'm a part of a team of 8 experienced physios and 4 S&C staff who rehab knees of athletes. And ACLs are our bread and butter, and I feel really lucky to work in such a good team who have been handpicked from all over the world, led by Enda King. So my role as the senior physio is pretty similar to a captain of a footy team. I'm consulting and treating with all the other physios in the team, and additionally, I seek to support the staff with the team from my experience and add value where I can. And our goal is to be recognised as the world-leading facility for rehabilitating knees, as well as all the other injuries and body parts that we have at Aspetar. However, in the knee space, it is very different to a football club environment in Australia, and because all we see is knees here at Aspetar. We see 90 every day of the week, which is quite a lot. And in my opinion, if this is all you're doing, you become very good at doing it. So we have a system on how to manage the knees to avoid common problems, which I'm going to go into a couple of them. And I'm lucky enough to have a world-class biomech lab run by Rula Rodesfaki and her team to review our athletes, which helps us ensure that we're targeted in our rehab and our rehab's on point. And our recurrence rate with a 2-year follow-up is less than 5%, which is pretty impressive in my opinion for ACLs. So the move itself, coming over here, was a big move for myself and my family, and moving from Sydney's Northern Beaches, and we've never lived outside of Sydney, and I'm really grateful for my wife in particular for coming over here and supporting me on this adventure with our young family. So that's a bit about my background and where I am now, Nick.
Mate, it's a lovely journey, and I'm really interested in the differences you're finding between, I guess, working professional sport and I guess now working in where you're at. What are some of your key learnings that you're sort of taking away? And I'd imagine you're sort of looking back on some cases you've worked with before and thinking, oh, geez, I could have done that a lot better, knowing what you know now. And I guess that's part of the development as a physio, but also, I'm sure you'd have a lot to take back to a club now. What are some of your key learnings around where you're at now, and what's it given you?
Yeah, I think overall, as a sports physio, you have to keep pushing and developing and seeking best practice on how you manage injuries. And I think how I managed an injury, say 10 years ago, to how I manage one now is different. And there's different nuances on how you do things. So um, I think you learn, and my learnings has been through developing relationships with experienced people in the field. And this is the best type of learning, in my opinion, is having a case and speaking to not only physios and medicals, but also management and S&Cs and coaches, as well as other senior managers. And I encourage physios to do this and not close off to the way that there's one way of doing things, and just open up your perspective to keep learning. And I think, as you mentioned there, Nick, before, not everything is peachy in sport. And I think you learn from things going wrong, and being self-reflective and going back and for the next experience, and how can you do things better for the next time. And I think it's really important to be self-reflective, and also seeking feedback from other staff to better yourself. And I think things that I change is, if I'm talking to a younger version of myself, is to seek more external consult from experts. And as a younger physio, you don't want to be seen as doing a bad job, so you try to take on everything. So I, at the moment, I get a lot of young physios and experienced physios who contact me regarding opinions about injuries, and it's something I really enjoy doing. And I think if your player is choosing to go to an external consult, that you sort of got to push them and steer them towards someone who you know and trust. And this is something that I really enjoy doing currently, is working with players and also working with staff from club to help solve problems. And
On that, mate, it is a really interesting point. What makes that a good process? And I guess I'm sure you've had experiences where it doesn't. So I guess if you're in a club and you're looking for an external consult to assist, when have you seen that go badly, and why? And I guess, how do you guys do it, or how do you do it that makes it work well for the club and the athlete?
I think, yeah, mate, I've definitely seen one go wrong. Uh, Player sent over, I'm not going to mention who the player was, and basically came back in worse shape than he left, and came back with a raging quads tendinopathy off the back of going to see a consult, but then tacked a bit of play off the back of that. So it was probably more him going off and doing the play after him seeing the consult that caused him some issues. So that's where I've seen it go wrong. And I think it's important to, if you are sending an athlete off, either know and completely trust the person who you're sending him off to, number one, or staff member needs to go with the player. So making sure that nothing is going wrong, and that the loadings are on point. So I think it can work either way. I think, as I just said there, if you know and trust what someone's doing, number one, and I think you need to be completely across the loading. So when there's a handover from going from the club or what's being currently done in rehab to seeing us over here, it needs to be a perfect little progression, and to avoid any flare up, really. So I hope that answered that question, mate.
It does, mate. I like it. And I guess, to that point, you're lucky to be in an environment where you are surrounded by many great physios and other experienced staff. But I guess, for those that aren't in that environment, how do you advise the physios to really keep learning and keep developing, to sort of go along the pathway, maybe if they want to go along the path that you've done?
Yeah, so I can speak on behalf of myself and what's worked for me, and I'll highlight exactly what I've done. I think, from my background that I've just mentioned, I've worked in rugby, I've worked in AFL, I've worked in soccer, football, as well as moving to Aspetar. So I think by simply moving and working in different environments, you learn from different professionals at different places. So that's been my biggest learning, is by doing and moving around. And I think, again, for me personally, I think I learn a lot from teaching and managing staff. So if you have a meeting or if you have a talk or if you have a conference coming up, you need to do a lot of work to prepare for those meetings, talks, and conferences. So I think you learn quite a bit from doing that. And then just ongoing learning, whether it be your football club, whether it be your private practice. At Aspetar, what we do, we have a lot of in-house learning, and it's very organised. We have case study reviews, we have complex case reviews, we have a lot of professional development PD internally, and this needs to have structure and it needs to be really organised to be successful. And in terms of, again, at Aspetar, I'm lucky where I work at the moment. Just a lot of the corridor conversations you have, like I was bowled up yesterday by someone who's worked in professional sport in the UK in rugby union. He's just, how do you manage a Sindes? And I told him my experience. So again, I think it's a lot of just having conversations, and if it's not internally, you need to seek them externally. And that's my next one, is external mentors. I'm lucky enough that I've got a number of people that I can call up and say, hey, I'm stuck on this case. What would you do differently? And I think a lot of the time I have the answers, and just talking it through with someone, they then go, you're on the right path. And that's how it is most of the time, is that you are on the right path, but they might go, have you thought about this? Have you thought about that? So I think having some good, solid external mentors that are sometimes not in your business or in your football club is really helpful as well.
Some very good advice there, mate. And you mentioned around the preparation for conferences and talks, and I guess even a podcast like this takes some prep. Recently, you've talked at a couple of bigger name conferences, which is the International Olympic Committee Conference and also the Aspetar knee rehab that was there last year. Can you fill us in a little bit about, just briefly, I guess, what you spoke to at these topics and at these conferences, and that might lead us into chatting a little bit around some clinical bits.
Yeah, so I presented at the Aspetar ACL conference last October. It was a very big conference with 400 plus people, which was very successful. And I liked how specific the conference was on one injury, with experts from all over the world. And at Aspetar, we also ran a pre and post conference workshop, which was also very popular and good as well. I presented specifically on explosiveness in ACL rehab, and so that's what I did as a part of that conference. There's another conference coming up this year on thigh muscle injuries with a star-studded lineup, so definitely one to put in your calendar for this coming November. And the International Olympic Committee Conference in Monaco was on injury prevention. What a venue, what a place. Our talk from Aspetar was on preventing secondary ACL injuries, and my talk specifically was on the sport-specific phase of rehab, transitioning from the gym to playing. And my recent experience working in sport helped me quite a bit in delivering this talk. And a handy resource for the listeners is the Aspetar Journal, Volume 12, which has some key principles on sport-specific rehab, which was written by a couple of my esteemed colleagues.
Great, mate. They look both of high quality, so well done on your presentation there. Mate, as we say, you are seeing all ACLs at the moment and working with a great team out of Aspetar. So let's talk ACLs. Yep. And I guess being such an extensive topic, and we could talk through it forever, what I want to try and do is, I guess, tease out, let's say three. We're going to talk through three common deficits that you see within ACL rehabilitation. And then the second phase of that is, I guess, how we're going to go about addressing them. So I guess it's a pretty open-ended question for you, but can you take us through probably, your top three deficits that you come across, and then we'll go from there.
Yep. Yeah, no probs. Just to start it off, probably not top three. What I wanted to do in talking about this was talk about a very simple deficit but then also talk about some other deficits which are a bit more sort of mid to end stage rehab as well. So I wanted to get different parts of the rehab to keep it interesting. But I did go around to the team of physios at work, and I did ask them, what are the common deficits you see? And they're all common deficits that we see and that we pick up. So the first deficit I'm going to start with, it's a simple one, and it's a big reminder to everyone that we've got to do the basics well. And it's just regaining knee extension. And knee extension is very important to regain within the first 6 weeks of rehab, and it can be lost if you don't work at it and regain it. Day one post-op, pre-op, I tell the patients the same thing. You've got to regain your range of motion, in particular your knee extension. You've got to decrease your swelling and regain a good active quad contraction. The sooner they can get this, the better it is for their knee and their recovery. And I also tell the athlete that the war is won with them doing this at home. They need to do their rehab at home, not just 3 to 5 times a week at physio, however many times you're seeing them in your week. They need to do their range work, they need to do their quad contraction, and they need to be putting measures around swelling management 4 to 5 times a day at home. And if they aren't active in this process, their rehab will be delayed. So some causes of a lack of knee extension it's most likely from swelling and a lack of active control of the distal quads, and they often feed into each other as well. Overactive hamstring muscles as well to try support the knee during walking, but also pain from the surgery and the injury to other structures in the knee, such as ligaments, bone edema, chondral lesions, and so on. Less likely causes of knee extension is the cyclops lesion, graft placement, thickness in the intracondylar notch, and graft tightness or meniscal tears or loose bodies causing mechanical blocks.
And I guess part of those causes, I guess it makes sense for us maybe to stay on that topic, and as you sort of work through other causes of that, we may as well, I guess it makes sense just to talk through, I guess, how we maybe address those causes, and then, how do we clean up that lack of extension?
Yeah, no problems, mate. So I think before we go on to the how, I think it's important to understand the why as well. So it's really important. So swelling, passive knee extension, and regaining terminal knee extension with a good distal quads contraction is important, as it simply just helps the patient walk normally without the knee giving away. It helps minimise their quad wasting. It helps improve swelling. And if you're walking around on a bent knee all day, they're going to start to get some anterior knee pain. So it's there reasons as to why it's important to regain it, but it also helps. If you have good terminal knee extension, it helps progress other streams of your rehab, such as your calf raise progressions. Having a nice extended knee leads into good toe-off progressions of rehab. But also, if we think about our reactive strength stream, having a good solid terminal knee extension helps us work and develop foot ankle stiffness and reactive strength, starting with toe taps, progressing to pogos, alternate leg pogos, single leg pogos, so on and so forth. And if it was me, I wouldn't run an athlete unless they had at least 0 degrees of knee extension. And what I aim for symmetry. However, 0 degrees is good enough. And to answer your question now, Nick, onto the how. So the athlete, they need to work on their active assisted range of motion using a seatbelt or a strap, whatever you use. And a common mistake I commonly see is that the patient's on the bed just really chasing knee flexion. So whilst ignoring the knee extension, and whilst knee extension is very important, it usually comes back a lot easier than passive knee extension. And what I get the athlete to do is when they are going out into knee extension, I really make sure that they're behind their knees nice and flat on the bed, and they're lifting up their heel off the bed and contracting their quads with it as well. Things that I usually avoid is I usually don't bounce on their knee anteriorly, pushing them into extension, because this can sometimes cheese off the knee. And I think it's really important to educate your athlete on what position they need to rest in at home. because as I said, they're only with you for 3 to 5 hours a week, right? So what are you doing at home? Are you resting with pillows chopped underneath your knee and then struggling to get your knee straight? So I think education's important there. In terms of isolated quad contractions, you need to find out what works for your patient here, and just having one method isn't always successful. So a method that I use is I like using a rolled up towel underneath their knee or a small roller underneath their knee, and the athlete doing some active assisted knee extension holds. And they usually do that with a seatbelt or with a strap. And how I start them off is I make sure that I put a Compex on, so initially to activate their quads, and then I also use the EMG biofeedback to give the athlete some feedback as to whether they're contracting that muscle or not. And the beauty of doing it this way, rather than the athlete just supine on the bed without the roll-up towel underneath their knees, that it takes their hammies out of the situation. And what I commonly see is that if you just supine on the bed with no towel underneath your knees, that they start to dig their heel into the bed sometimes, and they start to get overactive and use their hammies, and this can sometimes cause them pain if they've had a hamstring autograft. So I find that method is quite successful. Now, if they're not understanding how to do that and you're not getting anywhere with that method, an alternative is to get them in standing if they're able to, and get them to do a terminal knee extension with a band behind their knee. Sometimes this works with some athletes, and again, I use the Compex and EMG here for feedback. With all these methods, I palpate the hammies to ensure that they are contracting, and you can also use an EMG on their hammies to make sure that there's no activation here. And in my experience, a good solid prehab negates these issues and as well. So terminal knee extension, just to sum it up, it flows into developing good quad strength. And the reason why I've mentioned regaining this simple task is that I wanted to remind not only young physios, but everyone the importance of just keeping things simple in rehab. Developing knee extension, getting a nice quiet knee, getting good solid strength foundations, in particular the quads, is great for your knee, and it's also a prerequisite for the next couple of deficits, which I'm going to discuss.
Lovely, mate. Can you just touch a little bit further on your use of Compex and EMG for us, I guess? Touching more around, I guess, the intensity of Compex maybe, and also EMG. How do we use that in our clinic setting? What sort of device maybe do we need to purchase, and what's it give you a little bit that obviously it doesn't if you don't use it?
Yes. So in terms of the Compex, I usually use it pre-op, post-op acutely to help fire up the muscles. So I literally go as high as they can tolerate it from a comfort level in terms of intensity. And I usually do that for anywhere from 5 to 10 minutes. I get them to go through the warm-up cycle of it, and then I get them to actively contract whilst they're doing that quad exercise with the Compex. I then usually start the session off with that. Obviously, I've done my range of motion work beforehand, and then I move to Compex. And then with the EMG biofeedback, I think what we have is a machine where you can set the threshold. So initially, you're putting the threshold in the bar quite low and just seeing if the athlete can achieve a really simple, easy contraction. And as they get better, you can start to raise the bar a little bit higher. The EMG biofeedback that we use has a game with it, and we work with athletes. You know how competitive they can be, mate. So as they're contracting, a plane goes up and starts to collect some stars up in the sky, and when they relax, the plane comes back down to sort of a lower air zone, I guess, where they're collecting stars again. So it's important for them to switch on and switch off the muscle. And again, I progress the intensity as they can tolerate it. So that's how I use the Compex and the EMG.
Yeah, beautiful. All right, so number one deficit is clearly getting knee extension.
Yep.
And as you say, not top three here, just working through some common ones. Fill us in on your second.
So I've combined deficit 2 and 3 together because they do interrelate a little bit, but they are separate. So I'm going to be talking about reactive strength and explosiveness, and the reason being is that both reactive strength and explosiveness of the lower limb are both reduced in athletes post ACL reconstruction, with compensatory strategies that we need to be aware of. And what I mean by reactive strength is how quick or how slow our contact time with the ground is, and it's basically how reactive we are. And explosiveness is how quick we can perform a movement or an action. So many deficits exist in explosiveness and reactive strength jump testing, and if they aren't addressed, these deficits will become more apparent as we move further up the totem pole and with harder actions such as change of direction testing. And I think it's really important to understand how to measure these deficits, train them, and improve them and remeasure them.
So that's a really good insight into the strength and explosiveness. I guess, why is that important? It might be, pretty theoretical about why, but in your opinion, where does that come unstuck for us, and why is it just essential we get that in our ACL rehab?
Yeah, like explosiveness and reactive strength is really important. From a sports performance perspective, everyone wants to be fast. They want to have a great sidestep. They want to accelerate. They want to sprint. So everyone wants it from that perspective. We know that post-ACL reconstruction, both explosiveness and reactive strength decrease from the insult of the injury, from the surgery, pain inhibition, period of mobilization and swelling, which causes muscle inhibition and detraining of the muscles. So explosiveness and reactive actions, such as landing from a jump and the deceleration phase of a cutting action, are where the deficits lie. And they not only cause reduced sports performance, but also can cause non-contact ACL injuries. And these actions need to be measured. They need to be rehabilitated to negate the recurrence of ACL injury. And by doing so, you'll improve the sports performance of these actions.
All right, mate. Well, fill us in on, I guess, it's pretty extensive points here, but fill us in on how we go about.
We know that explosiveness and reactive strength decreases post-ACLR, and that they are common deficits. So this type of training needs to be commenced as soon as possible. Any athlete must earn the right to commence reactive strength and explosive training, and having set objective criteria helps clinicians make decisions on whether their athletes are ready to commence the training rather than just guessing. So the clinical examination of the knee needs to be quiet, meaning that the knee has minimal swelling and pain. And common mistakes that we see is athletes are being pushed too hard when their knee isn't ready. And it's really important to get strong, and I can't stress this enough. Stronger athletes are reported to express higher power outputs than weaker athletes, and having a good baseline of strength gives us insurance that the knee won't flare up when explosive and reactive strength training is introduced. So some criteria to commence the reactive strength curriculum is as simple as having full terminal knee extension and enough single leg calf strength to hold their body weight. They can then commence toe taps, and this is best done with hands on hips, full terminal knee extension, and tapping their feet without the heel touching the ground. And this can be achieved very early in rehab. It's important to progress this stream effectively. The athlete needs to have full plantar flexion active range, and this is another common deficit that I see post-ACL reconstruction. So criteria to commence the explosive training includes having a quiet knee, having again full terminal knee extension, and a decent level of quad strength, with the athlete being able to do a single leg squat down to a minimum of 90 degrees, and before they leave the ground and start jumping around, that their isokinetic quad strength is at 200% body weight. And this gives us insurance that having a decent level of strength, that the athlete has a decent level of strength before commencing this type of training to avoid any flare-ups. So then we go on to how to measure explosiveness and reactive strength. So this is simply done by testing, and the reason why we test is to basically provide the athlete with insurance that they are safe to return to play all progress through the different phases of rehab that we've mapped out. And there are many tests that are out there, and it's important to really understand why you're doing a test. If there are deficits off the back of the testing, we need to be able to interpret the relevance of the measurements and try change these deficits with the program. It's best to have a testing battery that's demanding and exposes the athlete to worst case scenario, because at the end of the day, majority of ACL injuries occur from a non-contact ACL injury. So how the athlete was moving prior to the injury may have caused them to get into trouble in the first place. And research has shown that there are shortfalls in testing only one component, such as jump heights or lengths, which are concentric measures. Athletes are reported to regain lower limb symmetry index for single leg hop for distance and regain symmetry and change of direction testing times, but still have significant biomechanical deficits in their affected limb. So simply looking at a hop for distance and change of direction times isn't good enough. And we need to dive deeper into biomechanics ideally, as this is gold standard.
Mate, from the biomechanics standpoint, where can, aside from sending our athletes to you guys, where can we sort of get some of that extra data from around the biomechanics? And can you just take us through a little bit more detail around what you might be seeing there and what we're trying to tease out?
Yeah, no problem. So basically the tests that we use at Aspetar for explosiveness include counter movement jump, a single leg vertical jump, and a single leg hop for distance. And the reactive strength tests include a double leg and single leg drop jump. So if you think about jump performance testing in ACL rehab, it's best measured looking at eccentric, concentric, and biomechanical measures. So looking at all three. And post-ACL reconstruction, the common deficits include concentric impulses, eccentric impulses, and landing forces. Now, just to explain what the impulses are, it's how much force is being moved over a period of time, and impulse is the area underneath the curve, and impulse can be divided into two components. You've got eccentric impulse, which is the eccentric phase of the jump, and the concentric impulse, which is the concentric phase of the jump. And usually post-ACL reconstruction, eccentric impulses are slower to recover than the concentric impulses, and there's greater eccentric impulse deficits, in particular those with patellar tendon grafts. Now, concentric impulses, in particular the P2 phase, which is the triple extension phase of the jump, is another common deficit we see. And again, if your athlete is struggling to push right off and they lack explosiveness, it's important to highlight it. And remember how I was talking about the terminal knee extension. If they don't have it, this is where it shows up. So the eccentric component of jump testing is an important measure, as this is where the non-contact ACL injuries happen. So looking specifically at eccentric impulse and duration and the landing forces, but to answer your question, looking at the biomechanics. So the beauty with the biomechanics assessment is that it shows specifically where the issue or deficit lies. So we have a number of performance metrics, which I've just explained, and we also have other performance metrics such as jump heights, RSI, and so on. But if an athlete, for example, has a decrease in eccentric impulse, why is this occurring? And how can we fix it, more importantly? So the common deficit we see post-ACL reconstruction is that athletes land on a knee which doesn't want to flex and absorb the load. Thereby, you see it wash out where they flex at the hip and trunk, and also they land on a plantar flexed ankle, and these are compensatory strategies. And there is less work being done at the knee and more work being done at the hip during this landing task. And this commonly affects the knee extension moment, which is a common deficit we see in the biomech analysis. And the knee extension moments can only be seen with 3D biomech with force plates. And again, this has huge rehab implications. However, not all is lost if you don't have the fancy equipment. You can use a jump mat, you can use an app that measures performance metrics for a single leg drop jump, for example. And vertical, the reason why I mentioned single leg drop jump is because the research shows that a vertical jump testing is far better than single leg hop for distance to evaluate the knee. And the single leg drop jump performance metrics such as jump height and RSI, it can be an additional clinical option for return to sport decision making.
Yeah, mate, fantastic take through. Would it be fair to say there that if I was doing my force plate testing and looking at this
Yep.
knee athlete, that just solely looking at the numbers alone would not be telling me the key information that I need to see? Like, as in, if we're seeing someone with that hip strategy you're talking, well, then numbers, they can still have decent numbers. Is that right? And is that where your sort of biomac element comes in to really break that down further for us?
Yeah, exactly right. So the what the biomech does, it looks at at the angles of so how they're moving, and it also looks at the forces and the direction of the forces. So that's what the biomech tells us. Whether they're just doing it on the force plates alone, you just get the performance metrics. So you don't get the detail as to what their strategy is and how they're moving. And I think this is really important. And a camera by itself doesn't doesn't show it. So the
Yeah, okay.
biomech is gold
It's,
standard, but as I said, not all is lost. You can still use force plates and a jump mat. Not all is lost, but yeah, biomech is gold standard.
yeah, if you really want to be teasing every little ounce out of that. Around those
And
metrics and I guess the jump numbers that you do touch on, and I mean, what are we looking at there, or what should we be aiming towards? Is it just
yeah,
purely limb symmetry, or are you looking at sort of different, numbers and percentages and things like that we might be targeting towards in our rehab?
yeah. So for our counter movement jump and our single leg counter movement jump, because we've tested so many athletes, we have an upper and a lower limit of what athletes should really be for their sport. We're looking at lower limb symmetry of um, less than 10% difference for eccentric, concentric impulses, and less than 15% for peak landing forces. And similar for drop jump and single leg drop jump, we're looking for symmetry or less than 10% symmetry for eccentric, concentric impulses and landing forces. For a double leg drop jump, we're looking at more than as a performance metric. We want their RSI to be above 1.3, and for a single leg drop jump, we want their RSI to be above 0.5. Um, and we also want less than 10% symmetry for their knee extension moments for their drop jump and single leg drop jump testing, and their knee valgus moments as well. So that's sort of like a quick summary of the metrics that we're looking for.
And the knee extension moments and the knee valgus moments, that's information coming from more of your biomech analysis. Is that
Yep,
correct?
yep, exactly right. Yep, correct.
Mate, that's some really great detail. I often get asked a lot around, everyone sort of wants a number to target, and certainly with RSI, it can be difficult when you're talking different drop dump heights and things like that. Just go back to your counter movement jump when you talked around your upper and lower limits. Can you give us
Yep.
a little bit more around that? I'm not sure if I caught all of that. I guess single leg counter movement and the double leg.
Yeah, so we've found through all the people that we've tested here that the upper limit is if they're doing a counter movement jump over 39 centimeters, that they're going pretty high for that counter movement jump, and the upper limit for a single leg counter movement jump is 21 centimeters. Off the top of my head, I don't have um, the the lower limits there, but that's what we're aiming for them to be up towards the top. Um, also
That's
athlete dependent, sport dependent as well.
Yeah, for sure, mate. That's spot on. Why don't you give us a little bit of your take through how you would address, I guess, breaking down those components around trying to clean that up in the rehab. So I guess through the reactive stream and a bit of an explosive stream, how you'd go about doing that.
Yeah. So I've spoken about the common deficits which feed into each other a fair bit, and we know that they decrease post ACL reconstruction. So we need to rehab them ASAP rather than letting them become a problem later, because we know that they do become a problem later. So if we have a deficit which comes up in periodic testing, we should already be working on these deficits. And our rehab streams help target these deficits. And there's an entry point to a rehab stream. So if we're thinking about reactive strength, for example, I've mentioned that we're starting with toe taps very early. So they should be doing that 5-6 weeks post-op. And then there's an exit point to the reactive strength stream. So that includes single leg tuck jumps or single leg drop hops. And there's lots of exercises and progressions in between those two. So I think with these exercises in particular, the reactive strength ones, we're looking at them really with quick ground reaction times, and the exercises need to be performed near or at maximal intent to get your best bang for your buck there.
Beautiful, mate. Can maybe I guess we're starting with some toe taps early, and we're finishing with things like the single leg tuck jumps you mentioned. What are maybe a couple of the ones that come in between to sort of bridge that gap?
Yeah, so we can move from the toe taps, progress into some pogos, then move into alternate leg pogos, single leg pogos, and then as a regression on those 3 exercises that I've just mentioned, you can do it band assisted. So imagine throwing a power band over a squat rack up high, and you just sort of pull onto that power band to help assist you doing that action. And then you can move into some progressions which really challenge that knee extension moment, is hopping backwards and forward over a line, and then you can hop backwards and forwards over a cone, and progressing to hopping forwards over a couple of cones, hopping back, hopping forwards over a couple of cones, hopping back one. So there are some progressions in our reactive strength stream, which we use. And as I said, you should be already using this, and then you're testing, because we test every 6 weeks. All our athletes get tested every 6 weeks post ACL reconstruction, and then we know they should already be using it. Oh yeah, it's come up as a deficit. I need to keep working through this stream until they're pretty much discharged, or until they've completed the discharge testing. So that's how it works.
All right, mate. Well, breaking down that explosiveness stream, and I know some of our tests, single leg, double leg, and the counter movement jumps are really looking at, I guess, the eccentric deficit and the concentric. Can you take us through a little bit about, I guess, how you might address that in each deficit component within our jump that we might be picking up from our analysis?
Yeah, so again, we have entry points and exit points for the different components of explosiveness. So if we're thinking about just starting off with the eccentric part of the explosiveness stream, this includes exercises such as drop catches, starting from tall and then dropping down to a squat position. So you can start with double leg and single leg, and you can really overload these as well. So what I find is that a lot of people do these exercises but they don't overload them. So you can use some dumbbells, you can use a heavy trap bar to really overload these exercises. And what this targets, it targets your eccentric impulse, and it also targets to improve our knee extension moments as well. And the coaching cue to really ensure that they're getting this is challenge their deeper depths, get them nice and low, get their chest nice and high, get that nice positive shin angle when they're performing these exercises. We then progress through to the concentric phase of the explosiveness stream, which is your non-counter movement jumps. So a good way to do a non-counter movement jump is jumping from a box or a bench. The only way you can go is up. So there's double leg and single leg progressions here. Again, overloading these in the Smith machine is great, or with dumbbells, or with bands, however you want to do that. And this then, if we think about our deficits in our testing, this targets concentric impulse, so that triple extension. And a good coaching cue that we use for that is make sure you're hitting your head on your ceiling when you're getting up, so they're fully extending out, and they're not extending out into a flex posture. And then progressing to our third part of our explosiveness stream, which is the combination jump. So it's your counter movement jump and your single leg counter movement jump. Again, we overload these with our trap bar, with our Smith machine, with our water bags as well, or our tidal bags, just to throw to challenge their motor control. And this works on both eccentric and concentric impulse. And with good technique, it also works on our knee extension moments. So I find it quite useful to measure how someone's doing their explosiveness and reactive strength. You can use jump mats, you can use force plates on a weekly basis, and it gives the athlete targets and goals. And a good way to progress all of these reactive strength exercises and explosiveness exercises is by changing the vectors. Vertical's hard, but then starting to add them moving forward and laterally is challenging. You can change their stance, so going from double to alternate leg to single leg. Resistance, which I've mentioned, also the speed that they're doing it. It needs to be performed at maximal or near maximal intent. And also exposure, how many days of the week are they doing it? How many sets and reps are they doing? And from an explosiveness perspective, we know that post ACLR, it goes down. So using a mixed methods approach, which is targeting all speeds across the spectrum of the force velocity curve is really helpful for improving an athlete's explosiveness. But there is a sweet spot in that strength speed zone, and using a VBT unit is really helpful for targeting that speed strength zone, which is 0.75 to 1 meter a second. So it's really important to measure everything, but I think the most important thing is what's their quality of movement like, what's their motor control like. And a common problem that we see is that athletes are doing really complicated exercises that look good on Instagram, but they're not ready for it. Or the other end of the spectrum, we see that they aren't being challenged enough. And I've mentioned the common strategies that and a common deficit that we see is that people are flexing through their hip and their trunk and not getting deep enough with their knee flexion with that nice positive shin angle. And this will help our biomech and our knee extension moment.
Super comprehensive run through there, I guess. I'm just going to go back around training the, I guess, eccentric component. If we're seeing someone with an eccentric deficit within their with jump analysis, obviously there's probably some things that contribute to that. You mentioned there already motor control, almost the training or the exercise itself might be a limiting factor, but also then, do you correlate that with, I guess, what you're seeing on some of the isokinetic testing and strength deficits? And how might they be addressing some of the strength deficits in the background and how does that link in with some of the exercise you mentioned there, the drop catches and the different elements to target that eccentric impulse?
Mate, 100%. Like, people need to be strong, and having strong athletes, as I mentioned in my first deficit, is a good solid foundation. So in the background of these deficits, in the background of us addressing reactive strength explosiveness, the strength team and the physios are working really hard on bringing up their strength. So isokinetic scores, we want them to be, for their quads, we want them to be at 300% body weight on their knee extension, on their ISO-K scores. So they need to be strong. They need to have good eccentric strength and good squat strength. And in your club, they need to be back in their performance zones, if not better, in PB Nick, really. So I think strength is so important, and I haven't focused on it that much, but it's a solid foundation, and I think all physios know how important strength is. So
spot on, and it was just something we thought we'd just highlight there in case anyone asks a question around strength. It's clearly, as we said, the question at the start was around some common deficits we see, and I think it's really clear that what you guys do and break that down from your jump analysis and looking at some of those deficits across the biomechanics, that some of those eccentric impulses and the concentric components are some of those key deficits. And mate, how you've run that through and our ability to, I guess, correct that has been quality. And I know that's sort of what you touched on with your Aspetar conference, and hence the reason we wanted to sort of reach out and hear from you firsthand here. So, mate, it's been a brilliant insight. So really appreciate that. Was there anything that you think we haven't covered off on that you wanted to? And also, second to that, how anybody can reach out and touch base with you. You mentioned your consulting clinic and obviously there at Aspetar.
Yeah, so people can get in touch with me a couple of ways. They can visit my Instagram handle, luke.heath_rehab, or they can go to my clinic website, www.hprsphysio.com.au, and browse and see and contact me there. So a couple of ways you can get in contact, and I'm more than happy for anyone to reach out if they have any questions or need any advice. I'm more than happy to get back to anyone in this space.
Mate, you're a star. Thanks for jumping on the How I Rehab podcast for SportsMap. We appreciate it, and we hope to do some bits with you down the track, and we'll be in touch, mate. So thanks again for your time.
No, thanks for having me on, mate, and keep up the good content and all the good work.